All right, hello everybody again, and welcome to our webinar. This is a part of AMCHP's collaboration lab from data to action using and translating needs assessment data. Just to quickly introduce myself, my name is Paige Lisinich, and here at AMCHP, I'm the Senior Program Manager for Children and Youth with Special Healthcare Needs. And I'll be introducing my other colleague later to close out our conversation today. So we already went over a few of the housekeeping items. So we already went over a few of the housekeeping rules. So please just make sure that that your line is muted, and you can do that by pressing *6 on your phone or using the mute function. If you need to step away from the phone for any reason, please do not put it on hold because we will hear your wonderful hold music. So please just hang up and then you can join again. You may have questions as we go through, and especially today we're going to have 3 different state presenters. So we'd really appreciate it if you would type your questions in as we go, and you can type those in the chat box here that's in the bottom right-hand corner. We will have a survey at the end of the call that we hope and encourage you all to complete, as it's really helpful for us in evaluating the success of our webinar series. Finally, just letting everyone know that the slides from today are saved in the file pod, which is in the top left corner that says Files. And finally, today's call is being recorded, and we will send that out within the next few days to you all to have access to that and to share with your colleagues. So really quickly, I'm just going to go over a very brief agenda. What we're going to do is we're going to hear from 3 states on their strategies in moving data to action. All 3 of these states are at different points in this process, and so it'll be really interesting to sort of hear the progression of that. So first we're going to hear from Oregon, then we'll hear from Alabama, and then we will hear from Michigan. To close out our conversation today, we'll have Cheryl Clark, my colleague here from AMCHP, close us out in a conversation in regards to inclusion, representation, and translation as we move from data to action. And then, of course, we will ask you to fill out a survey at the end. So really quick, just want to go over the objectives of this webinar and the leadership competencies. So I'm not going to read the objectives verbatim, but by the end of the webinar, we really hope that you have an understanding of strategies for initiating and sustaining partnerships and collaborations, specifically with stakeholders at multiple levels. And today we're going to focus on families, communities of color, and socially vulnerable populations, as well as identify effective strategies and best practices for partnering with culturally responsible organizations, as well as feeling like you're equipped with new skills for using and translating data from the Title V needs assessment into action. The leadership competencies that we'll be covering today fall under cultural competency, interdisciplinary and interprofessional team building, and family professional partnerships. So without further ado, I'm going to turn it over to the wonderful folks at Oregon Center for Children and Youth with Special Healthcare Needs. So we have 2 presenters joining us today. First, we have Allison Martin, and she is the Assessment and Evaluation Manager for the Oregon Center for Children and Youth with Special Healthcare Needs. She's also an evaluation consultant to OHSU's University Center for Excellence in Developmental Disabilities, and an assistant professor in the OHSU Portland State University School of Public Health. Her research interests focus on program evaluation and applied research design and methods, typically of community-based interventions that promote youth well-being. Her work focuses on assessing the needs of promoting care coordination in pediatric to adult healthcare transition for Oregon children and youth with special healthcare needs. So then also joining Allison, we have Cheryl Gallardi Kim, and she is the Assessment and Evaluation Research Associate for the Oregon Center for Children and Youth with Special Healthcare Needs, which is the state's Title V block grant agency for children and youth with special healthcare needs. Her interests focus on program evaluation and applied research design and methods, as well as assessing the needs of Oregon's children and youth with special healthcare needs, particularly those from communities of color. She supports projects that assess the needs of and promote care coordination and transition from pediatric to adult health care for Oregon children and youth with special health care needs. So Allison and Cheryl, I'll turn it over to you.
Thanks so much, Paige. Hi, everyone. This is Allison, and we're here to talk about a part of our 5-year needs assessment that's currently underway and for which we're using a participatory approach to better understand the needs of CHIN of color. We use the acronym CHIN for Children and Youth with Special Healthcare Needs. So the focus of our brief talk is to overview how we developed a scope of work and recruited partner organizations, to share key components of our partnership agreements, and describe our plans for including these organizations in our Title V prioritization process and dissemination, and conclude with some thoughts about our learning from this experience thus far, because we're hoping to use this approach in ongoing needs assessment with other communities. So to make sure that we're all on the same page, we first wanted to define what we mean by using a participatory approach. And the table on the slide there is from University of Iowa's Institutional Review Board, which shows a continuum of community-based research. And we're not going to take the time to go through the whole thing, but just rather to differentiate participatory research from traditional research. And thanks, Cheryl. So although the questions guiding our needs assessment were developed by our team, we are conducting our needs assessment with the 2 community-based organizations. They are participating or have participated in the development of our data collection methods, including our IRB protocol. They are collecting data and will co-own the data, and they will participate in analysis and dissemination efforts. Another example of how a participatory approach has been used with the Title V needs assessment is described in an article authored by Drs. Carolyn Wang and Sherry Pies, and we'll provide the reference for that at the end. So the National Survey of Children's Health provides a wealth of information but lacks results that generalize to CHIN, generally and particularly for CHIN of color. For example, we currently lack an estimate of the % of Oregon CHIN who are Black. So during our 2015 needs assessment, we received a tremendous response to our family and youth surveys, but they did not well describe the experiences of families of CHIN of color. And so for this needs assessment, we sought to test out this participatory approach in partnering with organizations that work in non-dominant ethnic communities to better understand those needs. So working, starting with point 1 on the slide, working with our colleagues, we identified 8 populations of children and youth with special healthcare needs on which we could obtain more data and have that be useful to our work and our partners' work. And so working internally with our other center colleagues, we started by identifying 2 of those communities to first test this approach with. We also wanted to work directly with community-based organizations as opposed to contracting with an external research firm. And the reason for that is that it allows us to develop relationships directly with community-based organizations working in communities of color and ensure that more of our funding goes directly into those communities. We began writing a request for proposal to contract with 2 organizations for this purpose. And we host, Ocean, our center, hosts Oregon's Family to Family Health Information Center. And one of our F2F parent partners used to work for a community-based organization that serves families of a non-dominant ethnic community. So we asked him if he could react to our draft RFP as if it came across his desk at his former job. And we went back and forth with him a couple of times. His feedback was invaluable, and that's why we put kind of stars around that point on the slide. We don't have time to go through all of the comments that he made, but one of his comments, and these are my words, not his, was asking why a dominant culture organization was seeking to own the information rather than information living within the community and us supporting the community and obtaining the information. So when we reflected on that feedback, we realized that that was an important role for our center to kind of flip us advocating for and instead supporting those advocating on behalf inside their own communities. So we decided to first start with a request for information so that could inform the development of a request for proposal. We wanted to use the request for information to gauge community organizations' interest in the work and their reaction to our proposed approach. We used those results, as I said, to revise our request for proposal that we had been drafting, and only organizations that responded to the RFI could respond to the RFP. And that slide, as you were probably looking at, it shows our steps and timelines. Okay. So our objectives for the data collection were to learn about the types of care and service needs of these children and families, their experience attempting to access the care, their experiences attempting to access culturally responsive care, and experiences with transition to adult healthcare providers. And so to accomplish that, we outlined 8 activities in which we wanted a partner organization to participate. So co-development in all of the steps of the work with the exception of the data collection, and the organizations are collecting the data themselves.
Okay, so this is Cheryl. We co-developed the partnership agreement with both organizations during our initial kickoff meeting. The purpose of the partnership agreement is to formalize partnership relationships in terms of laying out our expectations so that we all can move forward with focusing on the content of the project. The agreement provides guidance that can facilitate meaningful and authentic engagement on the part of all of us, all the partners involved. In preparation for this, we reviewed community-based participatory research literature about partnership agreements and pulled examples of what types of agreements should be included. So we shared those high-level examples with the organizations to guide our brainstorming session and developing the agreement together. This slide shows the high-level headings of the partnership agreement. So we start with our introduction and purpose, which I just said a little bit about earlier. And then we included our shared vision and goals. In developing a shared vision, we started off by sharing with organizations what we wrote in the RFP, which includes the mission of OCEAN and requirement and purpose of the needs assessment, and also to develop a partnership with the organizations who can help support their community in focusing on the SHIN population. We then had a discussion about what success looks like for the partner organization, their goals, and how to bring all of those together. Next are partnership norms, which are guidelines for the day-to-day functioning of the partnership and include overall project roles and responsibilities, communication pathways, like how we're communicating in terms of email communication, checking in, decision-making, and addressing conflict. Data sharing includes procedures for raw data sharing and data storage. We are using a secure OHSU box folder to share de-identified data. Development and implementation of data collection methods includes the process for IRB protocol development and data collection instrument development, and also the transcription process. Data analysis and interpretation explains that us at OCEAN and our partnership organizations will have shared data ownership and that we will support them in analyzing and interpreting data. And finally, the agreement includes dissemination of findings. In this section, we describe methods for disseminating findings, which can be through oral presentations in the community, academic conferences, media, published articles, etc. The partner organization and us at OCEAN will co-develop dissemination products to share findings with participants and local and state partners. So if us or the organization utilize the findings to develop other unique products after this project is completed, then we'll each provide the products to each other for review prior to publication.
So similar to Oregon's 2015 Title V Needs Assessment and Prioritization process, in January, We're going to, again, host an 8-hour meeting of stakeholders to review our national, state, and emerging priorities and solicit stakeholder input on priority selection. Representatives from our 2 partner community-based organizations will participate in the meeting. The roles that they have will be participating in a panel of other organizations that worked with our maternal and child health and adolescent and school health colleagues at the Oregon Health Authority. And our focus group data collections are just getting started, so our partners will be sharing our preliminary findings. Also during the meeting, there's going to be a breakout session that focuses on SHIN, and during the session we'll reflect with those community-based organization stakeholders and other SHIN stakeholders, such as representatives from local public health authorities and families of SHIN, about our priority options, directions that we're thinking about heading, reflect on some of the findings that were obtained from other needs assessment data collections, and also talk with them about the capacity of systems serving SHIN. And then our larger Oregon team, which includes our Oregon Health Authority partners, also will include our community-based organization representatives in the discussion of emerging priorities for the state.
In addition to the prioritization meeting, we'll present with our partner organizations at AMCHP this March. Our presentation is called Culturally Specific Service Organizations in Title V SHIN, Building Connections to Improve Equity for Oregon SHIN. And with one of our partner organizations, we also submitted a proposal to the International Congress of Psychology, which is going to be a version of the presentation we'll present at AMCHP, but it's specific to that one organization. One of our partner organizations would like us to come to Central Oregon, where they are located, and co-present findings at their regional stakeholder meeting. Ocean is also hosting a statewide conference in April. Our partner organizations will co-present findings at 2 breakout sessions during one of the days of the conference. So we at Ocean and our partner organizations both have interest in publishing our findings. So now we'll describe some key preliminary learnings about the process so far. We are housed within a medical university, OHSU, or the Oregon Health and Science University, so there are quite a few IRB requirements for our partners in order for them to be added as researchers or study team members to our IRB study. The requirements for that certification process include obtaining an OHSU external employee ID number, completing and signing an individual investigator agreement form, completing 2 online researcher-required trainings, which are the Responsible Research of Conduct and Human Subjects Research Training through CITI, and registering for an account with OHSU's online IRB system. So completing these requirements took our partners some time. Additionally, preparing the content of the project in terms of developing the IRB protocol, recruitment materials, and data collection instruments also took a lot of time. With one of the organizations, we co-wrote the IRB protocol together. They took the lead on some of the sections. And with the other organization, we led the development of writing the IRB protocol. What we learned in reflecting back on this process is that we focused on making sure our partners understood the IRB content, and we wanted the IRB proposal to be reflective of what everyone wanted to do. We were paying less attention to that certification process for IRB, so when we were ready to submit to IRB, we realized that we hadn't been well tracking that our partners still had pending IRB requirements. In terms of data collection training, each of the 2 organizations have different strengths and experiences with collecting data, and in the future we will have an intentional conversation earlier in this process asking the organizations for specifics about their experience collecting data and how to target increasing their data collection capacity. And reflecting back on this, we realized that we were so busy with the partnership agreement and IRB proposal and other responsibilities outside of this project that we didn't take the time to do that in a comprehensive way to have that intentional conversation. In terms of focus group facilitation training, we are exploring a culturally responsive approach. So the book that we use as a guide for facilitating focus groups is a popular resource by Kruger and Casey. We really like this book and do refer to it frequently. And as we were talking through this resource with one of the organizations, it was becoming clear to us that this book was written from a dominant culture and the U.S. perspective. For example, the book explains how to deal with 4 types of participants that you may encounter in a focus group: dominant talkers, ramblers, shy participants, and experts. The book suggests providing eye contact with shy participants to get them to engage more, or turning away from ramblers and dominant talkers to ensure other participants have a chance to talk. These type of participants make sense from a dominant culture perspective here in the States, but it may not make sense for non-dominant cultures in the U.S. or even non-dominant immigrant cultures.
And so we'll conclude there. We look forward to answering any questions. The references that we used are up on the slide, and thank you very much.
Wonderful. Thank you so much, Allison and Cheryl. So we have just a few minutes for questions specific to what Oregon just shared. So if folks have questions, please feel free to unmute your line either by pressing *6 or using the mute function on your phone, or you can chat your questions into the chat box. So we'll pause for just a moment. All right, so it doesn't look like we have any questions right now, but please feel free to chat those in at any moment if you do have questions that pop up as we go along. So next up, we have a group from the University of Alabama at Birmingham. So we have two different presenters who are going to join us. So first we have Dr. Ann Brizendine, who is a scientist in the Department of Healthcare Organization and Policy at the UAB School of Public Health, and she serves as the science director of the Applied Evaluation and Assessment Center. And Dr. Brizendine has a background in interdisciplinary research, strategic management, and publishing, which allows her to be an effective communicator of research and policy to a variety of audiences. Her research and scholarly practice focuses on a variety of topics, including autism spectrum disorder, developmental monitoring and early Head Start, statewide systems development in education and health, early childhood mental health, and perinatal epidemiology. Joining Ann, we have Dr. Julie Prescott, who is an associate professor in the Department of Healthcare Organization and Policy at the UAB School of Public Health. She holds graduate degrees in public administration and public policy, public health, maternal and child health, and occupational therapy. She has been involved both in the provision and evaluation of services and programs for MCH populations for over 20 years. Dr. Prescott has experience in program administration and direct health care provision for children and youth with special health care needs and disabilities, as well as needs assessments, research, and evaluation for early childhood systems. That includes evidence-based home visiting, high-quality preschool, early intervention, and social and behavioral models that address the wellness of young children ages birth to 8. Dr. Prescott is also the director of the Applied Evaluation and Assessment Center at UAB. So I will turn it over to Julie and Ann. Thank you.
Thank you both, or all. All right, thank you. We're delighted to be with you this afternoon. So we would like to tell you a bit of the story of partnering. Our story really is a progression of history, building on a very strong partnership and collaboration, and then being able to expand that more broadly from some history related to children and youth with special health care needs, and then moving into the other MCH population domains. So I'd like to acknowledge our partners who assisted in putting together the slides that you'll see here. As we'll go along, you'll hear that there are many other partners that have assisted with this project and continue to do so as we move along. But these are individuals who have been a part of helping develop this presentation. So where did the idea come from? So I mentioned earlier that this builds on a history of success and longstanding partnerships. So in Alabama, Title V programs are divided, much as you've heard from our colleagues in Oregon, in that the Children and Youth with Special Health Care Needs program sits outside of our state health agency. So Children's Rehabilitation Service is an organization within a larger umbrella organization, the Alabama Department of Rehabilitation Services, and that also, so it includes our Birth to 21 Title V CSHCN program, also includes early intervention and some programs for youth and adults with disabilities and vocational rehab. So that Children's Rehab Service, longstanding partnership there with UAB and the School of Public Health, especially here that we are a MCH Center of Excellence and have been so for many years. And early on, CRS focused on prioritizing family engagement. And in order to do that, also a very long-standing partnership with our Alabama chapter of Family Voices, so Family Voices of Alabama. The state co-director is also the state parent consultant at CRS. So embedded within that organization and a wonderful opportunity to partner for family engagement, not only with needs assessment, but beyond. So a bit of context and timeline. We were talking just yesterday about the beginnings of these partnerships, and we know that the first probably real official partnership was in the 2000 needs assessment. Again, this began in Children's Rehabilitation Service with an opportunity to engage at that time both with Family Voices of Alabama as well as the UAB School of Public Health, building on an idea of making sure that we had strong family engagement, opportunities to reach families whose voices might not otherwise be heard, and then the ability to partner with an academic university that had certainly experience in maternal and child health needs assessment, mainly to assist with capacity and to support the local CRS staff to be able to accomplish a really robust needs assessment. And so moving from that history of the 2005-2010, in the 2015 needs assessment, the Alabama Department of Public Health added a partnership with the UAB School of Public Health, again the MCH Center of Excellence, to increase their capacity as well to do needs assessment, especially with the more qualitative components. Certainly there was access to the more quantitative or numbers-based data and the state vital records and national surveys and other pieces of information that are very important for needs assessment, but really wanted some assistance in getting out to hear some of those local voices and family voices. So that partnership began in 2015, again with the UAB School of Public Health. And then you'll see that the addition of Mississippi Department of Health this year. So in the 2020 needs assessment, all these partnerships continue. And the exciting thing that my colleague will talk about is that we had a ready-made partner in Family Voices of Alabama for children with special health care needs here in our state of Alabama. As we moved into working more closely with the Title V Alabama Department of Public Health for the other MCH population domain, there was a need to replicate that and to have a similar family organization that could assist us in getting into these local communities. And so more on that in a moment. And then the exciting part then, so that's ongoing for the 2020, and then again taking this really strong partnership and the lessons that have been learned over time for those who have come before us and who continue with us to be able to replicate this in the state of Mississippi.
So then, as Julie was just mentioning, one of the big priorities for this 2020 needs assessment process from the Alabama Department of Public Health was really to revamp and strengthen our stakeholder and family engagement component, particularly in our focus group and qualitative data collection. And not only just get more folks, but diverse folks that we were not reaching prior to this cycle. But like any project, this was not without challenges. To be doing a bunch of focus groups across a big, oftentimes rural state, it's a really time-intensive coordination for getting those sites, getting the space, getting the people there, and so recruiting focus groups participants that are representative of the state. For those of you who are not familiar sort of with Alabama and the geography here, we're a very rural state, but we've got sort of a north to south interstate corridor along Interstate 65, where a lot of the effort is oftentimes focused because it's easy to get to, and those are the most populous areas, but they're also not necessarily representative of the experience of the whole state. So sort of branching out beyond that spinal cord of I-65. And then finally, I think everyone knows that we don't want to just take from communities. We want to compensate people for sharing their time, for sharing their stories and being generous with us with both of those. So with that, we provide incentives to group participants. But any of you who work in academic institutions or at state agencies know that oftentimes that can be really tricky to get incentives, gift cards. In our case, we did $25 gift cards to participants. And getting those approved and getting those distributed is often incredibly difficult. So with that, we sort of learned from our partnership with Children's Rehabilitation Services that they had a partnership with Family Voices, and we said, I wonder who we can work with for the broader rest of the population domains. And with that, sort of with some previous work and some networking, we ended up engaging with the Alabama Network of Family Resource Centers. And most states have sort of a different type of network of family resource centers, but ours, we have one in the state that coordinates with 17 member organizations. So they became our formal partner to host the focus groups, whether on site in their centers or at a library or a church in their area. Also recruit participants from their existing programs. They have the rapport, they have the trust with that community. So oftentimes that went very smoothly to say, hey, come talk about your life, share your experience, and get a $25 gift card. That was a lot, folks were more receptive to that coming from people that they know, whether it's a home visitor or a program administrator. And then finally, they handle the logistics and incentives. So each group, on top of the money to provide incentives to the participants, were given a small stipend whether to host childcare, transportation, or food for those groups. And then distribute the incentives. So as I mentioned, the Alabama Network of Family Resource Centers is a membership organization of 17 family resource centers across the state. And their goal is to support the development, growth, and continuation of family resource centers by providing TA, training, advocacy, resources, networking. And as I mentioned, group participants were recruited from existing programs in each center. And it was really a delight to travel around to all of these different FRCs and sort of see what they've got going on, because every center is slightly different because it's tailored to the community that they're in.
And just by way of reminder there as we move on, the process that we were just describing was our growth in terms of reaching the other maternal and child health populations in addition to CSHCN. So while we partnered in Alabama with the Alabama Network of Family Resource Centers to assure we were hearing from women and mothers and pregnant women, families, adolescents, and children in general, we continue to partner with Family Voices as well to engage families of CSHCN as well as youth with special health care needs.
We oftentimes refer to it as sort of two separate needs assessments, but really they're parallel processes under the same umbrella. And it's really been a fun experience sort of as I've come up as a student and now being on staff here at UAB, sort of seeing this process at different levels and being able to learn through different iterations to be able to pull through to this project. So when it comes down to process, the Alabama Network Executive Director, Robin Mackey, was able to make introductions between individual center directors and then me, our UAB staff lead. So I was sort of the point of contact because oftentimes UAB can become a bit of a nightmare to navigate through the bureaucracy. And so they had a single point of contact, and that was me. So then I worked with each center director to agree upon a date and then a target subpopulation. So whether that is one of those remaining population domains other than CSHCN, or we had a couple special populations, which I'll get to later, whether or not they could reach those within their center population. And then we, with our team, was able to provide a facilitator and a note taker for each group using a focus group guide that was developed between us, our colleagues at Alabama Department of Public Health, and then reviewed by the executive director of the Family Resource Center. And then Robin, the ED over at the Alabama Network, ensured that participant incentives and funding for the host center were distributed and made it to the folks to get out in time. So outcomes from this process. We did 17 focus groups, and as you see from all of these little white stars across the state, we were here, there, and everywhere. We wanted a geographically diverse set of groups, and we wanted to be able to hit all of the different public health districts. This is, as you can see, northern, northeastern. These are all of the different public health districts that Alabama Department of Public Health has divided the state into. Over the course of these 17 groups, we had about 150, 160 participants, which was vastly more than we had previously, both in total number and number per group. And we got every single Title V population domain with the exception of CSHCN, which, as we mentioned, were targeted separately. And then we also hit on some special populations that we knew that we wanted to make a little bit of an extra effort to reach. And that was the Hispanic or Spanish-speaking families. And those two focus groups were conducted in Spanish by a bilingual member of our team. We did a fathers group, which was always one of my favorites because these dads come in, they say, I don't know why you want to talk to me, talk to my partner, they're the ones that know everything. And then it's really difficult to get them to shut up. We had an hour and a half blocked out for these groups, and then really with every group, but particularly that fathers one, it was difficult to get them back out the door. We did a group, somewhat of a failed attempt at getting grandparents who were raising grandchildren, along with the LGBTQ group hosted by not a family resource center, but a group that was really eager to partner, and that the Family Resource Center was again able to help with those incentives and cut through some of the bureaucracy. We did a group of adult women with disabilities, which was geared towards women who were interested in parenting or were actively parenting with a disability, but really that one became a much more diverse group with the husband of someone with a disability, and they spoke about their experience seeking fertility treatments and trying to sort of get pregnant. We had family members of other folks with disabilities talking about sort of stigma and family support. So that was a really powerful group. And then finally we did a group of doulas because that is a health service that is really an emerging consideration in the state. And they had a lot of interesting perspectives sort of on cutting through a lot of the different social factors and racial and ethnic disparities in the state. And so as we mentioned before, we had a parallel process for CSHCN between CRS and Family Voices of Alabama. And so you can add, I believe, 6 or 7 additional stars to cover the whole Title V needs assessment process in the state. This was also not our only qualitative data collection process. We also did about 20 to 30 key informant interviews, primarily with agency heads, practitioners, providers, other members of the community that can give some insight. We had some really good ones with some faith community members, both a chaplain at one of the local hospitals and then also the director of a free clinic that is hosted by one of the mosques in the area. And then we also did several targeted surveys. And so we have about over 1,000 additional survey data points that we can incorporate into this process. And again, as Julie mentioned, we were able to replicate this process outside of the state of Alabama. So we worked with the Mississippi State Department of Health, and also apparently our stars sort of migrated a little bit. But those are the general.
We really didn't do any work in Louisiana.
But as you can see, where you can guess sort of where some of those stars were supposed to be. We partnered with Family Resource Center networks. Mississippi has 2. So Family Resource Center of North Mississippi, and then the Mississippi Community Education Center. And then to cover their CSHCN population in the state of Mississippi, we partnered with their USED, which is the Institute for Disability Studies at the University of Southern Mississippi. And all were great partners. I think we learned a lot about sort of what does work in Alabama, works about 85 to 90% in Mississippi. And as this process went along, we were able to learn sort of, you know, what was more important, whether it was snacks or childcare for some of those different things that the centers could offer. And then also we're really used to this process in our state because of the partnership with CRS and Family Voices, and being able to communicate sort of what we were doing and why in another context was a bit of a really fun and exciting mental challenge of trying to figure out that communication piece. So we learned a lot, and we're looking forward to replicating this hopefully in the next 5 years, I think.
And so as you think about any questions you might have for us, I'll just wrap up our little segment here in that partnerships and collaborations require care and feeding, and they require strong leadership. And we have been honored to work with strong leaders here in our state as well as in the state of Mississippi. So again, the Mississippi Department of Health, the Alabama Department of Public Health, and Children's Rehabilitation Service.
What is it about?
Long history there of leadership and supporting these partnerships and ensuring that we do the right things.
I can come in.
And
I can come in there now.
I will just,
Okay.
I'll just wrap up by adding that the other thing that we promised at every Family Resource Center and every focus group that we participated in is we don't want to be those folks that just come in, take information, and leave. So we're also committing to getting this information back to them, whether in one-pagers. I think what Oregon was talking about in the previous presentation about different strategies for disseminating this information. We want to make sure it gets back in the same way back to the communities that were generous with their time to really communicate how important and how meaningful the information and their stories are to this process. That's it for us.
Great. Thank you so much, Julie and Anne. We really appreciate you all presenting there. So we unfortunately don't have enough time for questions because we still have one presenter. So if people do have questions for Alabama, please do type those in the chat box, and then we can direct those and get those responded to for you all. So next, we have a presentation from the state of Michigan. So presenting here with us today is Lindsay Towns. She received her MPH in epidemiology from the University of Michigan and is now the Child and Adolescent Health Epidemiologist for the Michigan Department of Health and Human Services. She provides epidemiological, statistical, and geospatial analytics support to several programs, not least of which is Title V. So with that, I will turn it over to Lindsay to talk about data, health equity, and Title V.
Hi, everyone. I'm here to talk a little bit about how we have, in Michigan, been using our data to create a more equitable approach to Title V allocation. So I'll just go ahead and get started. So just a little bit of background on Michigan. Oops. Hold on one second. I seem to be having trouble clicking through.
Hi, Lindsay. It's Paige. I am sorry that that's happening. Let's
Figure out a solution. That is not it.
let me re-upload it as a PDF. 1 second.
All right.
Okay, here we go, Lindsay. We'll have to scroll through them, but hopefully they look good for you.
Yeah, and everyone gets a little sneak preview, no biggie. Okay, so just a little bit of a background on Michigan. Michigan is a geographically and demographically diverse state. We're divided into 2 peninsulas. The lower peninsula here is home to almost all of Michigan's population, with just 2 metro areas alone comprising about 2/3 of our entire population. And the entire upper peninsula is home to about 300,000 people. In the last 20 years, births to non-white mothers have increased by 23%, from 22 to 28% of all of live births. The majority of these births are to black mothers. 72% of births were to non-white mothers, and of births to non-white mothers in 2018 were to black mothers. And additionally, Michigan has seen a large increase in the number of births to mothers of Hispanic or Arab ancestry since 1999. And I'm just pointing that out because those are two ethnic groups that are typically classified as being of the white race in Michigan's vital records system, although their risk profile for a number of MCH outcomes is quite different from non-Hispanic, non-Arab white mothers and infants. So when we're talking about maternal and child health equity, one of the things that we see quite often in Michigan is that our non-Hispanic, non-Arab ancestry white mothers and infants tend to be at or above national standards for many, if not most, maternal and child health indicators. But unfortunately, we're still falling short for Black, Hispanic, American Indian mothers, Arab mothers, infants, and children in the state. And so in order for us to really move the needle overall on our MCH priorities, we need a systematic rethink of how to address these racial ethnic health inequities within our state. And for these reasons, Michigan adopted a health equity approach for our 2020 Title V needs assessment process. So we decided to take two approaches. Too fast. There we go. We decided to take two approaches to integrate health equity into Title V. The first was a more straightforward approach of looking at disparities in major indicators, and we focused on disparities between Black and white Michiganders. And the reason for this was both because of data availability. We have serious data suppression rules in Michigan, so some of the smaller populations, we would not have been able to share their data more publicly. And also because for most indicators, the other racial ethnic groups in Michigan, the values for those indicators tended to fall somewhere between those of the Black and white values. So, and the other approach that we decided to take was a social determinants of health approach to understanding root causes of divergent health outcomes. And that's what I'm going to be talking about here today. So a little bit on social determinants of health. So Healthy People 2020 defined these as conditions in the environment in which people are born, live, work, play, worship, and age that affect a wide range of health functioning and quality of life, outcomes, and risks. These can include both social and physical factors, typically not specific health variables, but rather things in the surrounding community. So we considered several possible data approaches for assessing community and social contributions to health, but we ultimately landed on using the Concentrated Disadvantage Index to assess social determinants of health for Michigan's MCH populations for our Title V needs assessment process. So a little bit about the Concentrated Disadvantage measure. It was selected by AMCHP as a life course indicator, and it integrates data on the percentage of individuals living in poverty, individuals living in households that receive public assistance, households headed by a female, population ages 16 and older who are unemployed, and population under 18 years of age at various geographic levels, so census tract, zip code, county, so that you can identify areas at greater or lesser disadvantage. And we opted to use these data to create a portrait of Michigan at the census tract level and to combine it with outcome variables, and I'll be talking a little bit about that process. So for our infant health population domain, we applied concentrated disadvantage to analyzing low birth weight. So the first thing we did was calculate the concentrated disadvantage score for each census tract using 5-year American Community Survey data, and then calculating concentrated disadvantage quartiles for every tract. We identified maternal and child health outcomes with high Black-white disparities or high regional disparities to assess by a concentrated disadvantage. Low birth weight was selected because it's both a relatively common adverse outcome and it has a significant Black-white disparity here in Michigan. We calculated the 5-year low birth weight rate by census tract using data from the Michigan Resident Live Birth File, which comes from our vital records here at MDHHS. We joined both calculated data sets to a map of census tracts in ArcMap, and then used multiple attributes to create a map symbology that depicts both low birth weight rates and concentrated disadvantage quartiles simultaneously. And this creates a portrait of both high risk areas and high adverse outcome areas simultaneously. And these two maps here are the inputs that create the integrated product with the combined symbology. The map on the left is the low birth weight rate in Michigan, whereas darker colors represent a higher than average low birth weight rate. The average statewide in Michigan is just about 9%. So anything in that light blue color is average and below, and the darker blues represent above average low birth weight rates. Concentrated disadvantage is on the right, and these each color in the scale depicts an increasing quartile ranking of disadvantage from the 5 combined variables that create the concentrated disadvantage scale. Darker colors then representing higher disadvantage areas. And these two maps were essentially combined to create this somewhat more patchwork-looking map of low birth weight by concentrated disadvantage quartile. So I'll walk you through how to interpret this map really briefly. Each of these separate color ramps, the green, the blue, the purple, and the red, represent a different quartile of concentrated disadvantage. The darker colors within each ramp represent a higher tract-specific rate of low birth weight births. So that light red color, if you look at the high disadvantage in red, the light red represents those areas with a high disadvantage with a low birth weight rate, and the dark red represents those high disadvantage areas with a quite high low birth weight rate. And so we can see that we have high concentration of high disadvantage and high low birth weight rate tracts in Michigan cities. I've done a pop-out here of the Detroit area, and you can see there's a high concentration of both red color in general, which would represent the top quartile, the highest quartile disadvantage, and of the dark red in particular, which are those high disadvantage areas that have a high low birth weight rate. But even within the city, you can see a high degree of heterogeneity, both for the disadvantage metric and for the low birth weight rate. So you can see areas here along the coast where we have both a low disadvantage index and a low birth weight rate. And there are other areas within the city that vary as well. We did see a significant positive correlation between concentrated disadvantage and low birth weight rate. But one thing that we found sort of interesting was in the high disadvantage areas outside of cities, they tended to fare better in terms of the low birth weight rate. And also those areas outside of the cities with high low birth weight rates did not necessarily ping as high on the concentrated disadvantage index. So a few takeaways. These maps, along with other data on health disparities, were presented at our Title V population domain meetings. These were population domain-specific meetings for each of the major groupings that included stakeholders, including public health workers, members of the public, policymakers, and so on, who met to learn about and discuss the health needs of each population domain. In those meetings, we found that people who worked in our local health departments were interested in the prospect of using this or similar analyses to identify high-need areas in their communities for better targeted interventions. One thing that became clear is that the concentrated disadvantage index seemed to work better at identifying high-risk urban areas than in rural areas. So as I said before, we had several high low birth weight rate tracts that had a low concentrated disadvantage quartile rank in the northern, mostly rural parts of Michigan. And this was also true across the other analyses that we did, including for things like teen pregnancy and our Children with Special Health Care Connection to Care analysis that was done for the other population domains. So going forward, we'll be using this kind of analysis to work with both state and local programs to identify high-need areas for services. Being able to work at the census tract level allows us to identify neighborhoods within cities, towns within counties, and so on for better targeting of our interventions, to identify those populations that are at the highest need in a social sense and in the highest need from an outcome sense. We're going to work on developing Michigan MCH-specific data indexes that can identify both rural and urban areas with high needs. Our Native American population here in Michigan tend to live in a more rural area, and we know that they have a quite high disadvantage for a number of these components, but they're sort of being glossed over in the larger data set. So what we're working to do now is identify component variables that are most strongly correlated with adverse MCH outcomes in both settings. And if this requires doing 2 indexes, then so be it. But, and we're also looking at ways to meaningfully integrate our social determinant of health findings with Title V priorities and requirements. And this is, of course, tricky because Title V has a lot of prescriptions about how money can be spent and where. But currently, we are using these types of analyses to inform our state priority measures and to help our local health department select their local priority measures. And with that, I am done and open to any questions. Thank you.
Thank you so much, Lindsay. Really great way to wrap up the content there. So really quick, I know that we are running out of time here, but I am going to turn it over to my colleague Cheryl Clark, who is the Associate Director of Epidemiology and Evaluation here at the Association of Maternal and Child Health Programs. All right, and I'll go to her while she begins to talk.
Hi, this is Cheryl, and really quick, I want to give compliment to our 3 sets of presenters as they showed you kind of a variety of ways that they are, trying to make the data and the processes more inclusive, more representative. So my, brief kind of final closing comments is just kind of an overview of some things to keep in mind as we go through the data world and try to make it more reflective of our real life situations and populations. So final notes, and I'm hoping Paige got me back on track. Thank you, Paige. And so right here, I really am not going to go over the graphics too much, but there's this serve as examples of how even though we have data that's before us or maybe tried and true, we still need to look and see if what we are capturing and if that is the right data set to be using, or we need to note its limitations. So in these 2 examples that come from the Urban Institute are talking about the 10-year census and how it has been known to consistently undercount the Black population, and so what Michigan was saying is that they use some data to see where services need to be had and all that, but if you're undercounting 2%, 4%, or even back some years ago, up to 8% of the population, you may be missing that, and it's all depending on who you're undercounting, because those may be the areas that may require different resources or extended resources or more intensive resources. And if those are being undercounted, how are you going to make sure that you are accounting for that missingness, and also, to relate to your programs on who they need to be reaching out to and serving. And also, too, with the thing going, all the issues going on around immigration, there's a fear with the 2020 census, which is, a few months out from being enacted, that a lot of folks may be nervous about presenting themselves to be counted. And so what will that mean in your areas? And so just kind of understanding the whole context of census, and also, too, with population-based surveys. I think we as epidemiologists or data people or program people automatically think that everyone's included in surveys like the PRAMS and the National Children's Survey. But I would just advise folks, look at the data notes and see that sometimes they'll tell you, like, you can't break this apart in this state by race because we weren't able to sample, or we oversampled a certain population or certain condition. So just be aware of those things when you're working with that data. Next, please. One of the things that we are trying to do, and I think that folks on this call that presented were, kind of adhering to this, is a call to decolonize data. And I just left a direct quote from Montana Budget and Policy Center document that was on the internet, that too often that we have data that doesn't really paint a picture, paints a good picture of who's impoverished, maybe populations in needs, and kind of focuses on, kind of the disparity piece. And that is important because I know from personal experience that some folks don't see that, they don't think it's important, and they overlook it. So we have to find this balance between showing those things, but also showing some positive aspects and resourcefulness of those communities. Next, please. And so this is a direct quote, what decolonizing data means to Abigail Eckel-Hawk, and this is straight off a website in 2019, who's gathering the data, who's interpreting it, and are we interpreting it in a way that truly serves our community? So it's more about, having that input from, I think, our first presenter was talking about focus groups in Alabama, I think, or was that second? I can't remember. The second presenters, and including the people that you're actually making part of your observations and what they need to, what represents them, and marrying that with some of the traditional measures. And so you have to do that in order to, we know that health is a holistic and a community-based influence thing, so we need to make sure our data is that way too. Next, please. One measure that was heavily talked about from Michigan, our last speaker, was community disadvantage, and AMCHP does have a collection of life course indicators, and concentrate disadvantage is one of them. Another one that we found that is kind of mirrors concentrate disadvantage is economic hardship index. And these are, kind of tried and true. We want to show those areas of disadvantage and usually, overlay them with, areas of health conditions and events. And that is good, and that is kind of a sturdy thing we've done for a while. Next page, please. But one of the things that we can look at is that, these are the variables that are coming from the census data set. And they're kind of, notice that they're looping around kind of income, and things that are really, really correlated with income. Education, we know the higher education that you are, the more likely you are to have a higher paying job per capita. Crowded housing, public assistance, those are very, very looped in. So you get these measures in this index, but they're highly, highly correlated, and there's really not a lot else going on besides dollars. Okay, next. One of the things that AMCHP is interested in incorporating into our life course indicators is more, for lack of a better term, kind of more resourceful indicators. This is one that was suggested to us from the field, actually. It's called the Child Opportunity Index. And so, like I said before, we've had traditional measures where the focus has been on SES and little focus on, or no focus on, the community and neighborhood resources. So this index aims to measure the neighborhood conditions that influence child health and development. Next, please. Well, there are three groupings, and that's educational opportunity, health and environment opportunity, and social economic opportunity. And you can read what goes under there. Now, you look at the social economic, you kind of see some of the things we saw with concentrated disadvantage. But in the health, educational opportunity and the health and environment opportunity columns, you'll see more about, school proficiency, school poverty within local, and an emphasis on local schools, proximities to early education, and then along with high school graduation rate and adult attainment rate. Health and environmental, more the closeness to health facilities, the retail food environment, how close folks are to toxic waste and release sites, and number of parks, and then how's our housing vacancy rate. Now, one of the things we know, this seems to be more expanded and a more rounded look, but we will, acknowledge that it's going to take you longer to get to that, and it's going to be probably more of a local look than a national or statewide look. But, if you go to their website, and I didn't have time to put it up there, is datadiversity.org. They have different maps that may be in your, states, but also how they've used this to kind of compare within, different geographic regions. And I think that this offers, like I say, a more rounded. Next slide, please. I'm sorry. So one of the things that we always look at when we look at data are these 10 data quality characteristics, and I won't go over them, but, are they timely? Are they current? Are they accessible? Are they accurate? Are they comprehensive? Are they consistent across time and across population? How precise they are? But also, too, when you're thinking about health equity, how can you use those data characteristics to incorporate what you're trying to do and include and represent your population that you think may be neglected or left out of those other traditional data sources? Are you assuring that the definition, are you assuring that, whatever you're measuring, you can measure across populations? Is it comprehensive enough to include those people that may have traditionally been undercounted or misrepresented in the data set? So all of this is centering around quality. No, that's good. All of this is centering around quality. So when we are assuring data quality and these 4 major roles that we use for data, with the application and the analysis, the storage, and the collection, are we assuring those 10 characteristics exist in all those things, as far as collection, as far as how we're analyzing it, how we're presenting that data, how we're translating it out. And so that is basically it in a nutshell. So I just wanted to kind of give a high gloss, of thanks and appreciation for the folks that went before, and then also kind of what we need to take home with all their diverse methods that they use. We all just want to be inclusive and talk about quality and make sure we're counting our people appropriately and doing something with the data. Thanks.
Thank you so much, Cheryl, and thank you to everyone for staying on just a few extra minutes so we could hear some final thoughts. For those who are still on the call, are there any lingering questions or clarifications you'd like us to make before we close out? All right. Well, I will be sending out a follow-up email that will include the link to the recording and as well as emails of the presenters that we had. So thank you all very much for being here, spending time with us this afternoon, and a special thanks to all of our presenters. We had Allison and Cheryl from Oregon, Anne and Julie from Alabama, and Lindsay from Michigan, as well as Cheryl to close us out from AMCHP. So thank you all very much, and we look forward to hearing you soon. If you could fill out the evaluation link that just popped up on your screen, we'd really appreciate it. Thank you.